good. Perfect. Yeah. No. Yeah. Well, yeah, we're struggling with the IT. It's only because I'm the most skilled. Ladies and gentlemen, I'll just ask you to start taking your seats, please. Okay, thanks everybody. Thanks, ladies and gentlemen. If you would mind taking your seats. Thank you very much. Welcome back. Okay. Is the room a little bit more comfortable for you now? Yes? We'll try and keep it comfortable but not too cosy for the day. Okay, welcome back everybody, and welcome back also to our rural and regional colleagues who are joining us by video conference. I know we have one question from our rural and regional friends, and we will incorporate that into the next panel discussion. So thanks for sending that in, and please continue to send through your questions from the rural parts of Victoria as we go through the next presentations. We're moving into a session which is called Designing Interventions to Reduce Occupational Violence. I'd like to make sure we've got all of the presenters from this session up the front just to make it a little bit easier as we go through the program. So if you're presenting in this session and you're not already here, please feel free to move forward at this point. We're going to start with Tiffany Plummer, and Tiffany is the After Hours Coordinator and the coordinator of the Aggression Prevention Program at St Vincent's Hospital in Melbourne. Tiffany's going to start this session on practical interventions that are occurring in health services. She's going to talk about, we're all in this together, the collaborative approach to aggression prevention and management. So thank you, Tiffany.
Lovely, thank you. Hello everyone and welcome. So I was really asked to talk a little bit about the St Vincent's perspective around a collaborative approach to dealing with aggression prevention and management. I think I'd like to sort of link a little bit with a comment that Janelle and Patrice made, and that is that we've already mentioned a little bit about collaboration, and I think particularly over the last few years there certainly has been an increase of collaboration, not just within our own organisation, but certainly with external health services and other services. So I'm just going to explore a little bit about how we've gone about doing that. And I think it's also worth mentioning that particularly over the last 3 or 4 years, the discussion really has moved away from ED and mental health and looked at a whole of hospital approach. And that's something we've really strived to do at St Vincent's, that we have aggression and violence everywhere. And it doesn't just happen in the areas that we think it happens. It happens to our reception staff, it happens to our community or lone workers, it happens to people who are non-clinical, as well as clinical staff. So I think it is really important that the shift and the focus has moved to a whole of hospital. So just to give you a little bit of background about some of the statistics that we've got at St Vincent's, we see or have around about 3,600 code greys a year. Broken down, the vast majority, or about 1,600 of those, happen in ED, about 800 happen in mental health, and then we certainly have about 1,000 codes that happen in the main area of the hospital. So again, that just kind of proves that it's a whole of hospital problem. We had about 40 code blacks last year, and we have actually seen an increase in our code blacks this year. And there's a number of reasons for that, which we're currently drilling into. Part of it is that we're having issues around discharge of people, particularly people who are homeless. And we're also seeing incidences of aggression around grief and bereavement, and families really struggling to contain their anger around grief and bereavement. Last year we had reported 239 physical assaults on staff. Now, a vast majority of those are actually quite mild. They might be hair pulling or a wrist being pulled, particularly with ADLs around patient care. But there are a number of those incidences that actually are quite serious too. And we only had 118 reported incidences of verbal assaults. So that, I think, is one of the biggest issues we face around reporting. So I can tell you what, there was more than 118 incidences of verbal assault. I most probably saw about 50 to me. So, you know, we don't report enough. So just having a little look around what we do internally in regards to collaboration. We're a big team. It's not just one person who works on occupational violence. And just to show a little bit of what we do, we have a culture at St Vincent's where, from an OH&S point of view, safety is my responsibility. What that means is that we're all part of this team together, and that we all actually have to have some awareness and some understanding, be involved in the training, know what the policies and procedures are around aggression. So it's really important that from an OH&S point of view, we make sure staff are aware of what their responsibilities are as well. Security is absolutely vital to maintaining a safe workplace, and we have an in-house security team at St Vincent's led by a manager who's been there for a long period of time, and the security team are absolutely essential to the workings of a co-grey team, but also in maintaining a safe working environment in regards to looking at environmental upgrades, being involved in discussions and meetings around where we may need duress or CCTV coverage. They're approachable, they're reliable, and they're certainly seen as integral to the workings at St Vincent's. The other thing is that our security are notified on a daily basis about people of concerns who are coming into our facility. So we have an alert system that notifies our security of people that we've currently got maybe some issues around their safety. And they also get notification of where our prisoners are. So St Vincent's has a correctional health facility within it, and they pose quite a different risk to our staff. So we make sure security have some understanding about the prisoners that are coming in. In regards to mental health, recently what we've been working with mental health is reviewing our mental health ADAPT training, but also post some incidences that we had a number of years ago. There was a task force developed that's since been disbanded after it did followed up some recommendations from investigations. So what that was, though, was it was a great way of showing particularly staff what happens after a serious incident and the investigation that happened. We've had Code Grey at St Vincent's for 27 years. We're pretty well embedded in this process. We have a 6-person team. It involves a medical clinician, because a lot of the aggression you see in a hospital is clinical aggression, and it absolutely needs to be addressed by someone who is clinical, and that includes medical and nursing. We also make sure that everyone who works in the organisation has some understanding around Code Grey. So again, they were talking earlier, Department, around that tiered response. So we even make sure our volunteers and our angels get aggression training. It's fairly minimal, but they have an understanding of what are the resources available to them. We have a great relationship with our executive. We speak to our executive at the Executive Safety Councils, and we provide briefings to them around what's going on in the OV space. We do a lot of work with our clinical staff, and we do tailor aggression training to their needs. So recently we've been rolling out a campaign or a training program around methamphetamines, just to increase their awareness about methamphetamines and what that might look like if you're dealing with a patient. We work with our clinical liaison to make sure that if we've got a patient under the Mental Health Act on the ward, that we're meeting requirements, and also utilising Code Grey with a sense of a trauma-informed approach. And I just also want to mention our STAR program, which is integral when we're looking at how we collaborate. Part of the work I do is I coordinate a peer-to-peer support program at St Vincent's. It's actually one of the case studies that the department has put out, so you'll be able to read up about it. But what that does is provide 24-hour support to staff post any clinical or critical incident. And we find that staff utilise the program quite readily. It's now in its 20th year. And so if there is an incident of OV, there are people who are available straight away to provide psychological first aid. So that's a really great program that I think staff have really responded well to. We also, going around our circle, we work really closely with our emergency department and our emergency coordinators, who basically attend Code Greys and any code during the 9 till 5 period. And as an after hours coordinator, I'm responsible as well as being part of the Code Grey team after hours of the hospital, and they are highly skilled clinicians with quite significant amounts of years of nursing behind us. So they have an authoritative position of the hospital and are able to really deal well with clinical aggression, particularly when we're dealing with difficult families. And my job as the aggression coordinator started out of the Building Better Partnerships program quite a number of years ago. I've been in the role now for about 8 years, and it's been great to see a lot of other health services really pick up on my role, which is really a bit of an oversee role of the aggression prevention framework at St Vincent's. I am, along with a colleague of mine, Barb Stevens, a bit of a go-to person to sort of talk to staff when they're dealing with aggression and prevention measures, and also a great resource to have someone to sort of bounce off what is going on outside of the field as well, and to update people. So I think it's been great to see St Vincent's take on this role, and now other health services have seen how beneficial it is to have. Moving on to an external. So what do we do externally? A number of years ago, we joined with the Victorian Police and made a video about how to bring a patient with an acute behavioural disturbance to our facility, and how to do that in a really safe way, both for the police, for our staff, but also for the patient. And so they use that in their training. We've established a police liaison. So we have a police liaison with Fitzroy Police. It's the senior sergeant from Fitzroy Police. That role is not determined on who is in that role, but it sits within position of the senior sergeant at Fitzroy. So whoever sits in that role actually just takes on being the patient liaison for St Vincent's. It's a wonderful role. It helps our staff, particularly if they feel that they'd like to speak to the police after an assault or need some advice about how to go about charging. There is someone who can give us some expert advice about that. We have formal and informal meetings with our police liaison, and they work quite closely with mental health as well, looking at people who may have absconded or any patients that we've had some real difficulties with. We also have had some gun safes introduced into our facility over the years, and we've also, what we do with Fitzroy Police is their senior sergeants come to our site and meet some really key people such as the NUM from mental health, the ED director and NUM, and some of the emergency coordinators. So they're very much part of our team, which I think has been really, really key in building some of those external networks. The other thing we've recently engaged with maybe about 18 months now, maybe 2 years, is the PACER program. So we have staff who go out with the local police normally in the afternoons into the evenings, which has assisted in dealing with patients with mental health issues. So that has certainly helped provide some really good common knowledge around what we do as a healthcare service, but also making sure we're really providing good clinical care out in the community. We also work closely with corrections because we have corrections facility in the hospital, but we also have staff who work down with youth detention and down at Port Phillip as well. So we make sure we have a really good working relationship with the staff. We have a dedicated corrections liaison officer who is a really good, again, person to contact to find out any information that we might need. And we also have developed over the years a specific code in dealing with prisoner issues, which is a code Ivory, which is fairly unique to St Vincent's, and that's around about how to deal with a prisoner who may be becoming agitated or aggressive, but also a prisoner who may be attempting an escape. So we need to make sure that our staff are fully aware of that code. So in regards to other things that we've done to collaborate, to really look at how we manage OV, is we have a number of committees. And some of those are the Emergency Codes Committee. We have an Aggression Prevention and Management Committee. We also have an Emergency Services Liaison Committee, which is attended to again by Corrections, Police, Ambulance Victoria, Community Mental Health, ED, a representative from the General Ward, myself, and an After Hours Coordinator and an Emergency Coordinator. And our emergency coordinator, Barb, is part of the Central Hospital Emergency Management Committee, which was developed 5 years ago, and that was about connecting hospitals in the metropolitan area and sharing some really good information. The other thing that I've seen that has happened or has been a change over the last few years is that health services are much more willing to share what we do with one another, and I think that's been a really big change. I think before there was this idea, well, if I write a policy, it's mine, but I think we've gotten really better at deciding, you know, we're all in this together. This is not just one health services problem, and if we can share information. So being on the Aggression Forum, which has been going for about 2 or 3 years now, has something that's been really, really worthwhile, and I would really encourage those health services who don't have a representative to come and speak to myself or one of the people from that group to find out how to join. We meet 3 or 4 times a year at Thomas Embling normally, and it's been a really great development. So I think I'll leave it there. I'm getting the nudge that that's my time. So a lot of information in a very short space of time, but thank you.
Thanks, Tiffany, very much for sharing what you're doing at St V's. It's always been a leader and always been at the forefront of this sort of occupational violence issue. And there's obviously a lot been happening there. We're going to move on. The presentations, just a reminder that the presentations will be circulated to you all after the forum. So, and they'll be available, I think, on the website as well. We're going to move on to hear from Ballarat Health Service about a regional approach, and we've got Marcus Hovey, who's the manager of the Management of Clinical Aggression Coordinator at Ballarat Health Services, and Marcus is going to talk to us about what's happening in the Grampians region. Just also to let you know, I've received a couple of questions now from our regional colleagues, which is great, and we'll add them to the panel at the end of this session. But at this point, over to you, Marcus. Thank you.
Just get the slides. Good morning, everyone, and thanks for having me and listening to me today. What I'm presenting today is again on collaboration, and I think will be a common theme coming up today, and also to build on what Tiffany was just saying as well. And this is one of the initiatives that we started at BHS a little while back. When I came into the role in 2014, it was very soon after that. Just getting the slides up now. And it is about collaboration across the Grampians Healthcare Network, and I'll go into a little bit more about what that is in a moment. We've got a long history at Ballarat Health Services of collaborating with the smaller regional networks within the healthcare sector as well, and also with the department's regional office as well. So it was fairly much a natural thing for us to do. Okay, it's up and running, good stuff. And I've been with Ballarat Health Services for a long time, since 1992. I'm a registered nurse, and I've got a passion for education and training, and so much so that I ran away for a couple of years and became a primary school teacher. And then I came back into this role, and I thought, well, this is a really great package that I learnt about when I took on the role. We collaborated with a lot of people, including Melbourne Health and the department, and also our regional partners as well, and it's been fantastic. I'll just give you... That's just a map of our region. It's fairly big, and there's a lot of health services within that region. We're the largest health service, of course, at Ballarat Health Services, and there's Ararat and Stawell, Skipton and Beaufort, right out to the border, out at Edenhope and District Memorial Hospital. And I even had an auntie working in the Harrow Bush Nursing Centre, and I don't know if you know that, but it's a one-nurse place. And it had everything. It was an ED, it was an outpatients and a mental health clinic all in one. So this is the region that we work in, and I'm very passionate about sharing our expertise from BHS across the region, and I love the region too. I've lived there all my life. We also took in some partners outside of the region. We took in Castlemaine as well into this, and so they're part of the Loddon, I think it's the Bendigo region as well, but they came into this as well early on in the piece. So it is a large area. Oh, done the wrong thing again. Got it. All right, so what have we done? Well, first of all, this came about talking about code greys of all things. Back in the time when the principles came out, I started at the same time. So first day on the job, write a new protocol. Okay, all right, here we go. And so Pat Standen, myself and Alicia Bedgegood all met. Pat's the regional Department of Health and Human Services person that we liaise with, and also the smaller regional healthcare services got some money around grant money to help implement Code Grey in their areas. And a lot of them had a lot of issues around resourcing. So we're lucky at BHS, I suppose. We've got security, we've got staff, we've got environments that we can secure, all those sorts of things. But the regional hospitals, the further you go out and the smaller they become, it's harder to manage this as well. Most places only have 2 people on at night. Police might be half an hour to an hour away, so it's not that easy. And so you're looking at the principles of what was in the department guideline. You go, oh gosh, how do we do that here? And I have to do the same for BHS as well. So we engaged with the regional healthcare networks through this. Initially it was the Code Grey meeting, and we did some video conferencing. And it was, identified early on in the piece that we needed a training package as well to go with this. And it's talking about that whole of hospital approach again, what Tiffany was talking about. It is the MOCA model as well, and we took on Melbourne Health's MOCA model as well at BHS. So first of all, we had to engage with the regional healthcare networks, so the directors, people who are interested in this space, OH&S managers. Many people have many hats in the region. Not sure if you know about that, but if you've got an interest in safety, you're it. Okay, and also the director and managing rosters and all sorts of other bits and pieces as well. We'd already engaged with Melbourne Health. BHS had already done that before I'd started in the role. I became a MOCA trainer and we started implementing MOCA into BHS, and I thought, oh, what a great idea, let's do it to the region as well. Didn't know how big it was going to be, but it was. Also, so Royal Melbourne Health School and Northwest Mental Health came into that, and a couple of the colleagues are here today, Vicky and Nigel, they're there. They're waving now, as I see. So engagement was really important. So BHS coordinated the training in the region and facilitated by Melbourne Health. So it was a really big project in the end, and it takes a lot to get all those people coordinated. I don't know if you've ever tried to get a birthday together. It's a much easier thing to do, or even a wedding. But this was a lot of fun, really engaging, really hard work as well, just trying to get dates and times and venues and spaces and all those sorts of hassles that you can get, and agreement and who's paying for it. That's always the thing as well. Really important. So it took on a life of its own, on top of what I was already doing at BHS as well. It wasn't in my job description to do this. We just thought, why not? So we actually changed my job description to add it, which was really good. So if I, don't do it tomorrow, then someone else is going to have to take it on, which is really nice. Some of the benefits for us that, I suppose for me, working at BHS, you're the only MOCA trainer, you feel like a bit of a shag on a rock. So it's really nice to have some support. And likewise up the road and down the road, because it goes from Bacchus Marsh right to the border, having that support network in place is really important for trainers. And I know that Melbourne Health already have this in Northwest Mental Health, in Royal Melbourne. They've got a bunch of trainers and they support each other, which is really great. And I was just here last Friday and did a refresher of my own, sat in with the Melbourne Health team again, and that was a really good refresher for me. So it's really important to get that support. Also, what we're doing is building capacity in the smaller health services to manage consumers with aggressive behaviour. Sometimes they have to go and bypass and come to us. So it's not a great outcome if the person that's being cared for can be cared for in their community but has to come to us because of their behaviours. So it's building future capacity. And BHS has been doing this for some time in other areas around bariatric management and the like as well as building clinical capacity in the region. So for us, this is quite a normal thing to do. We have a coordinated consultative meeting as well, which is really important because we have to keep everyone up to date. And we're in line with, we also coordinate that with the regional quality meeting and also the regional OH&S meeting, all on the same day. The MOCA trainers also meet just before that OH&S meeting. And thanks to Pat again, she's taken the credit now, and for organising the room, the venue, the space, video conferencing, all the things that I don't have to worry about, which is fantastic, or Alicia in our management team. And we meet in Ararat, so it's sort of in the middle, somewhere in the middle there. It's a bit of a drive, but that's okay. So that's one of the things that, how we keep this going. Back in 2015, halfway through the point, just going back a little bit, we did the initial Train the Trainer program, and we had 7 health services on board and 11 trainers, were able to come to that training. We delivered the training in Stawell, so quite up the road. So thankfully Melbourne Health were able to get away for a whole week, which is a big ask, and were able to come up to Stawell and deliver the training. So, and then they were able to support the trainers after that with credentialing, which happened mid-2000, or just before the middle of 2016. Now, at the moment, the regional trainers, Ararat's certainly taken off with MOCA, and it's a whole hospital approach as well. Everyone at Ararat, including the volunteers, also come to training, and they've developed their Code Grey protocols with MOCA principles in place. So it's becoming really sustainability for them. They've also lost a trainer. That's unfortunate. They did have 3 originally. Now they've got 2. Stawell is also implemented, and some new people that have come online this year are Djerriwarrh and Skipton and Beaufort. There's plenty of more that also want to come online as well. We did have some barriers. The distance is a big one. There's 45,000 square kilometres that the region covers. That's bigger than Belgium. So that's just an idea. If you've ever been to Europe, we're talking about bigger than a country. Resources and funding, that's always a problem. Most trainers have their other roles. I'm lucky, this is my role. But in the smaller health services, I know that Wayne at Stall, for example, he's the OH&S safety manager, he's doing safe patient manual handling, and now Mocha on top of that. He did get an increase in EFT, I think it was about 0.2 all up, so that's handy. So he's able to get to the meetings, he's able to free up some time, but he has to deliver the training just like myself as well, so the training does take some time, but that's okay. And also ongoing support and credentialing for trainers. That's a big one as well, because we have to make sure that the program stays a quality program. We can't have trainers going off on their own tangent. We need to deliver consistent quality training across the whole region. Quality, not quantity, is what I say. It also comes down to, you know, my education background. I've got to make sure it's right, and we've got to get the right message out there as well. So there's some barriers there, but I don't think they're you know, it's hard work, but I don't think I think they're barriers worth breaking down. So what's next for us is the ongoing sustainability. At the quarterly meeting just this month, we were talking about the very thing about, well, what happens if the Mocha trainers that we've got credentialed and take something else on? What do we do? Okay, so this is a discussion that we're currently having at the moment. We still engage with Melbourne Health, of course, and hopefully that we can get another Train the Trainer program up this year. But we have to look at that more long term. How are we going to sustain this? Because everyone's really busy, and it's very difficult to get people away for a whole week to train more trainers in this space. We do share resources, so that's fantastic. You know, code-grade protocols fly thick and fast through my inbox, so that's really good. And ours is up for renewal again this year. We continue to engage with the department. That's really important. We need them in partnership. And the reason why we need the department there as well is because there's multiple health services. And I think with the department, there's a bit of a guide there. If they're involved, then people will show up to these meetings. People will engage. And I think that's really important. The other health services that we're reaching out to that aren't in Mocha yet are West Wimmera Health, right out at Nil, so right near the border. And also Wimmera Healthcare Group as well. So they're a fairly large organisation in Horsham, which is really good. So it's all about sharing and collaboration, the Grampians regional approach. There is also a case study in the WorkSafe brochures as well that we've put together. So, and if you want to know more information, my contact details are there. So I think they're in your show bag today from WorkSafe. But other than that, thank you very much. And this is something that we're really excited about at DHS. Thank you.
Thanks, Marcus, very much for that. Marcus will join the panel later. You can ask any questions of him that you would like to. We're going to move on to hear a subacute case study on environmental conditions for aggression management, and that's going to be presented by Will Halpin. Will is the Associate Director of Occupational Health and Safety and Wellbeing at Northern Health. So thank you, Will, for joining us.
Thanks, everyone. As per the introduction, I head up the OHS and Wellbeing team at Northern Health, so I'll be presenting a case study from one of our subacute sites with a bit of an OHS lens, and going on from a lot of the discussions that we've had this morning. We know that aggression is spread right across the work environments in healthcare, and subacute is not immune to that. So I'll push on. Oh, the other down button, thanks. So I'll be talking about Kath Atkinson Wing, which I'll refer to as KOW from now on. It's a 15-bed secure geriatric and evaluation management unit at our Bundoora site. So we've got 5 sites at Northern Health, and this is located in Bundoora. So it's spread. We share the site with Melbourne Health. They've got a mental health component to the building. Our part of the building is sort of spread across 2 wings, and I'll show some photos shortly for some context. One wing being nominated as a high-risk sort of area, and the other wing being low risk. So they're all single rooms. In the high-risk area, the single rooms have got their own ensuite, and the low-risk share ensuites. The average length of stay is 30.5 days, and the patient cohort are those patients with behavioural and psychological symptoms of dementia. So we see a lot of difficult behaviours, a lot of intrusive behaviours, patients that are agitated, a lot of verbal and physical aggression as a result of that as well. So the model of care aims to maximise the patient's strengths and to embed a person-centred care approach. So a lot of diversional therapies and so on as part of the care planning. So the admission criteria there, so a diagnosis of dementia and comorbid conditions that require behavioural assessment and management. We do see the majority of the patients are 65 plus with delirium and behaviour management issues, but we do have occasionally patients below 65 years that are referred by ACAT with other behavioural management issues. So an example there might be a younger patient with younger age onset dementia and Down syndrome, for example. So the patients come directly admitted from home, residential care, acute care, or from other subacute care. So some photos for context of the site. So it's on our Bundoora site, which is a nice sprawling sort of site with plenty of natural light and gardens. As you can see there, the bottom photo is the back of the KW unit. So we've got access to a garden there. There's a little gazebo and a bus shelter. And that's used frequently in the warmer months, but obviously at this time of year it's not that welcoming to be going out there. I guess it's important to note that this unit was not built for the purpose of which it's used right now. So it's not a fit for purpose facility, and that's you can see that that's quite clear when you look at the internal photo there. There's a lot of hard surfaces. There's a lot of noise that bounces off those hard surfaces. So it is quite loud. And when you're dealing with patients with the types of behaviours that I've described and the sorts of conditions that I've described, you can see that that could lead to issues, particularly with the noise and that increasing agitation. And that's certainly what we find in KW. So a little kitchenette area there as well, which can be used for diversional therapies and also by the staff. So this data is all OHS, OC violence and aggression incidents reported across Northern Health since June 2015. So you can see there a steady increase across the organisation. We're the same as every other organisation in that underreporting is a problem for us. What I would say though is that KW, which is top of the list there, has a really good reporting culture. So 1/3 of our OC violence and aggression incidents reported across all of our sites come out of this 15-bed unit, more than our emergency department, which is the busiest in the state. So we've got a great reporting culture, and I think that's probably due to a number of things. It's probably due to the work that we've done with the team to encourage them to report, and starting to see some tangible improvements that I'll be talking about shortly, and a really good culture of teamwork in that unit as well, that they look to support each other and report these incidents. So we do sometimes see multiple reports of the one incident coming through. So if anything, there might be some over-reporting, but I think if anything, it's probably accurate to what we would see there. And obviously for all those other areas across our different locations, quite underreported. So my team about 2 years ago started working with KW quite closely to better understand this aggression and what we could do to help them to address it. We started with some staff safety perception surveys. So this is a survey that you'll find in the WorkSafe guidance material, and some alarming findings. So 50% of the staff telling us that they did not feel safe at work. 74% of the staff telling us that they did not feel sufficiently prepared to manage aggression or violence at work. 50% telling us that they were that they perceived to be experiencing aggression on a weekly basis, and 88% telling us that they believed that we could improve the work environment to better manage aggression and violence. So clearly from some work for us to do as an OH&S team and together with the local team there and site management to improve. So in terms of the risks that we identified as a result of the staff safety perception data and also working with them in focus groups, there were plenty of risks that we identified both to staff and to patients. So we were seeing an increase in aggression and violence. This was physical harm, it was hair pulling, it was pinching, it was behaviour that was verbal as well. Self-harm was a concern, and also absconding risks with the patients. So this was leading to understandable distress amongst the patients, their family and our staff. And the cumulative effect over time was obvious as well, that it was really having an impact on the staff in terms of that vicarious trauma over time as well. So we're seeing increased absenteeism as a result. We were seeing an increased likelihood of staff injury and the human and financial costs that are associated with that. And we were having difficulties in retaining and attracting skilled staff to work in the space. So not a good place to be in, and plenty of work for us to do. So we worked with the team to better understand what does it look like for them if there's 88% of them are telling us that the work environment could be improved to better manage and prevent aggression. Well, what would that look like? So we did some consultative risk assessment with them, and up on the slide there is what we call a bow tie assessment. It looks kind of convoluted, but it's a fairly basic risk assessment approach in a focus group context with the staff. So in the middle there you've got the hazard, which is aggression in KAW, and on the left-hand side there you've got the contributing factors that lead to that aggression. So broadly we categorise them into three main areas of environmental, human and clinical contributing factor areas. And then on the right-hand side you've got the consequences. So if the aggression does occur, then what do we see as a result? So we see staff injury, we see patient injury, we see potential workers' comp claims and the financial costs and so on. So in the middle, we have the risk control. So these are the things that we've got in place to manage the aggression and prevent it from occurring. And the items that are in blue there are the things that we identified as having in place. So they were risk control measures that were there at the time, and this is going back 2 years now. The blue boxes with the orange borders are those things that we identified as having in place but perhaps weren't up to scratch, benchmarking with across the sector and looking at the literature. And then the orange boxes are those things that we didn't have in place at all to really work on. So this approach allowed us to prioritise with the staff what would you see as being most effective in addressing these risks, to allow us to put an action plan together. So then on the other side you've also got the consequence control. So should the aggression occur, what have we got in place to mitigate this risk from being as bad as it possibly could be? And the sorts of things that we saw there, portable duress alarms, EAP, peer support and so on. So in terms of the environmental risk controls, we're probably all aware of the department funding that started a couple of years ago for infrastructure and capital works. Doing this work allowed us to put a case to DHHS for that violence prevention fund, and in particular the equipment and infrastructure work. So unfortunately we weren't successful in the first round, but very pleased to say that we were successful in the second round. So thanks to the department for reconsidering our application there. And the work that we did leading up to that application, particularly that consultative risk assessment approach, allowed us to put a really good case together. So the sorts of things that we were able to implement, and some of this is still yet to come, were from an environmental risk management perspective. We looked at sound absorbing surfaces. So looking at the literature, we knew that noise and high stimuli was really leading to increased agitation and aggression. So if we could manage the acoustics in the environment, both in the public spaces and in the bedrooms of the patients, then that would help to manage the aggression. So we're installing sound absorbing surfaces in those spaces, so on the walls and in the ceilings, putting a new dividing wall in the common area, so between the high and the low risk areas, so that we've got a bit more management and separation of those patients. A roller shutter grill in the ward kitchen, so a space that our staff can go to in the event that a patient is becoming violent, that they can have a space that's safe for them. And managing light and privacy, one of the things that was raised as part of the risk assessment approach was the issue that we had around windows and curtains being pulled off the windows by agitated patients, that was resulting in those curtains sometimes being used for self-harm or harm to others as well. So if we could better manage the lighting, that would lead to better sleep, obviously for the patients, and privacy as well. And obviously the cost of replacing curtains was becoming quite a problem also. So we looked at double glazed windows and also internal curtains between the windows so that the staff could better manage the light for those patients who needed that managed for them. And also looking at our duress alarm system, so upgrading that so that it went back to a central command centre and having on-person duress alarms for each staff member. So these are just some of the risk controls. There was a whole bunch of other stuff that we did that's non-environmental, so looking at improved training arrangements as well, and competency-based training in particular. We did have an online package that had been implemented in years gone by, but we really needed something that was a bit more robust, and that's been rolled out over time also. So coupled with these environmental risk control measures, it's a broad approach to managing the risk. So just by way of example, that's a makeshift improvement to one of the windows that we did have. And here we have the new windows that have been installed with the internal blinds, so quite a significant environmental improvement. We're also partnering with NARI, so the National Ageing Research Institute. They're doing both pre and post intervention evaluation with us. So using some structured tools that are up on the slide there, they'll be looking at qualitative and quantitative data to assess the success of the interventions that we've applied. And we'll be looking to get that published as well. So be keen to share that across the rest of the sector, I'm sure, once all this has been rolled out. But as I was saying, some of those environmental risk controls are still yet to happen, so this work is currently underway. So we'll be looking at our incident data, we'll be undertaking those staff surveys and continuing to work closely with the staff in this space to improve our processes for managing aggression. Thanks.
Thanks, Will, very much for that. And again, there'll be an opportunity to ask questions to explore a bit more of that later, but thanks for that interesting presentation. I'm glad you'll be glad to see I've got someone capable with a computer who's supporting me here now so we can move through the slides well. Our next presentation is from Ainsley Sense. Ainsley is the Director of the Footscray Emergency Department at Western Health, and I think she's quite new in that role, maybe 3 or 4 weeks, 2 months, so congratulations on that appointment. And Ainsley is here to talk to us about emergency department perspectives. Thanks, Ainsley.
Thank you everyone for having me here today and listening to my story. We've been talking a lot today about how this is not just an emergency problem, but it is an emergency problem, and that's what I'll be giving you the perspective of today. So I have 3 hats on. One is that I'm an emergency physician. I've been working in EDs for nearly 15 years. The second is, as advertised, I'm the new director of a Footscray emergency department and have a vested interest in supporting my staff and my patients and keeping them safe, and also an interest in designing a new hospital that facilitates that easily. And my third hat, which is why I'm probably here today, is that I'm chair of a working party within the ED, which is called the ED Occupational Violence and Aggression Working Party. And it's a multidisciplinary team looking at these specific issues in the emergency department and trying to move forward in improving them. And we have been lucky enough in some ways to have some really serious incidents which have gained some traction over the last 2 years, and I'll talk about them soon. I was actually asked to talk about my journey in the occupational violence sphere, and when reflecting on this, I actually thought to some incidences that happened over many years, which I probably didn't pay attention to at the time. And the first was in a shopping centre with my mother, and I was approached by a very muscly, tattooed young gentleman who approached me fondly, said hello, and went on his way. And my mother, my very conservative mother, was quite shocked. And she asked me who that was, and I said he was my bodyguard. And she was further shocked, and I just thought it was because she didn't understand what I did as a job, but she was more concerned that I needed a bodyguard. And obviously he was one of my security officers, and I had a very good relationship with him. I should have realised then that probably what I did was not normal. The second instance is my husband. So when I took my soon-to-be husband to one of our first ED Christmas parties together, he found the security guards and befriended them. And he told them to protect me, and I thought that was kind of manly. But I now realise he was actually quite concerned, and it's interesting because I wasn't concerned, but what these things were telling me that other people were concerned. And I probably didn't become concerned until I had a belly, and I became very vulnerable, and I felt very obvious, and that's when I started to feel scared, and that's probably the first time. So that was probably after about 10 years of working in an emergency department. Subsequent to that, we've had several quite significant incidents, mainly in Sunshine Hospital, staff being strangled, and staff being hurt, and then the biggest incident was at the end of last year, which triggered a work-safe investigation, and that was when a patient, after 19 hours in the emergency department, managed to get into the fishbowl, assault a nurse, break the jaw of another doctor, and be crash tackled to the ground by 2 of our other staff. Obviously, there was lots to review from that incident, and our working party have thrived since then, I must say, because we've had to really seriously look at what we've been doing. And so when I break down what we have been doing into some subtitles, we've really been looking at a few different elements of occupational violence: the culture, statistics, our preparedness for it, our early detection, any management strategies, and prevention. So if I just talk about culture first, I can definitely see my transition has gone from normalisation and maybe a bit of tolerance, possibly a little bit of ambivalence, to now feeling aware and engaged with the process at work. But I can't say that this is the same for everybody else. And actually I've seen a change over the last 6 to 12 months of anger, cynicism, frustration, and even people being afraid. Now, tolerance and acceptance and normalisation is not good, but anger and frustration and cynicism is also damaging, and we need to work out how we're going to get people back to being aware and engaged, and that's part of my job in all my 3 hats, but also all of our jobs here today. Because at the end of the day, as much as I know it's not our job to be abused or assaulted at work, it is actually our job to manage behaviours. And so the term clinical aggression before was very apt. That is actually my job in an emergency department. And it will happen because the emergency departments are awful places for people to control their emotions in. And in fact, we're probably lucky that people are able to control their emotions to the extent that they do, or else we would have many more incidents. We've talked a little bit about reporting, and our data does not suggest at all that the incidents are increasing. I think everyone in this room would see that there's a flaw there. And in fact, I would love our data to show that they're increasing out of sight, because that would mean that our staff are actually reporting them. Same at Footscray, we had a drop. We had a drop over 2015 to 2016, despite the incidents that were happening. So what are some of the things that we're actually going to do about this? So we're looking at preparedness, so looking at early notification and being a little bit more aware of what's coming in the front door. So the obvious patients coming in the divvy ban are really easy. It's the other people who might have risk factors or might have previous behaviour who are a little bit hard. The incident of the 19-hour patient raised this very clearly, because in fact he had had behaviours of concern prior to arrival that either weren't handed over or were documented, and then after a few more handovers in the emergency department it was lost. And so we're trying to make sure that we capture this at the front door by adding a little behaviours of alert box where the allergies are, to try and, it's very simple, but just try and make sure that we think about this at the front door. Our alert systems are flawed. We have 3 different IT systems that do not communicate with each other. I'm sure that other people have the same problem. We've been told that we can't fix this. But what we can fix is people's awareness, and we did some surveys last year on how many people knew how to check an alert on our EDIS system, and it was atrocious. 70% of the doctors had absolutely no idea. Even the ones who did have an idea didn't actually do it very often at all. And some of that's because every time you check an alert, you get 10 penicillin allergies, or the fact that the UR number's been merged, and there's no way of actually deciding whether this is a significant alert for you on this context or not. We don't have a strategy for that at the moment, but education is one of them. To be prepared, you need to know what the risks are, and we did some data audits last year about the diagnostic groups that make up our code greys, and I don't think it surprises anyone here that nearly 75% or more of code greys were related to patients who had alcohol and other drug issues or mental health problems. Now, we've grappled with this data quite significantly in our working party, because what we don't want to assume is that all mental health patients are violent people, nor that anybody who has a problem with alcohol and other drugs will display behaviours of concern. But they are risk factors, and I think we need to be very clear about that. How we adopt this into our practice isn't clear to us yet. And we're by no means labelling people with black wristbands or anything like that, but we at some stage need to look at how we try to stratify risk. I'll just skip through this part. So the biggest area that we're working on at the moment is in early detection and prevention, and one of the things that we noticed from our 19-hour case was that there were several instances in which the nursing staff were concerned and had attempted escalation without any outcome. And it was very clear that they either felt unconfident in detecting the behaviours, or not empowered enough to actually escalate further if they didn't get what they needed. And so we have actually adopted a behaviours of concern observation chart into our normal nursing observation chart at Western Health. It's going to be rolled out in the next, well, we'll say month or two, knowing how the charts take. But this has been a very successful thing that we trialled at Sunshine, and I'll just explain it a little bit further. So essentially we're using a violence prediction tool. It's the only validated one that we could find. It's not validated in the emergency department, so it was actually designed to be used on the wards on a shift-by-shift basis. But it's very simple, and it gives you a score out of 6. So every behaviour that you have, you score 1 with a total of 6. And then the way that it works is that if you score 0, you have a low risk, not a no risk, but a low risk of violence, and above 2, a high risk of violence. And then we've designed a matrix to go with this to empower people to know what to do with that score. We do it hourly on our patients in the emergency department, and we thought that this was going to be cumbersome, but in fact the nurses have really had positive feedback about it. They now know how to assess behaviours of concern, and they now know how to escalate their concerns. It's actually even being extrapolated into code grey reporting and riskman reporting. So when a code grey is called, you can see very clearly the documentation has been that the BOC score has been 3. And so I think in a very, very quick time we've had a lot of uptake of this concept, and as I said, it's being rolled out. So there's the matrix that we have. It doesn't probably really, well, it shows okay, but essentially it gives the different roles a different task for each of the scores, and that's how it's going to look when it actually comes into our observation chart. We've decided to keep the matrix in the observation chart for the moment, because unlike measuring heart rates and blood pressures and things, this is a new thing for us, and we want to really make sure that people are still understanding it as we try and adapt it into our practice. Moving on to management, I think the management of the really highly aggressive patient who comes in the back of a divvy van is really easy. Maybe easy is not the right word, but we know what to do about that. We get a team approach, we put them in a certain place, we try and de-escalate. If we can't, we restrain them in various methods, and we gain control. I think the big sphere in that space is actually to do multidisciplinary training like we do for all kind of resus and critical incidents, and try and tighten up the way that we do that. It's the management without warning that's actually much trickier. And what we again noticed from the 19-hour patient was that we didn't have a very clear way of notifying the team. We also didn't have a very clear way of notifying the other staff what was going on, and we didn't have a very good way of keeping the surroundings safe. So the notification of the team sounds really easy. You call a code grey, but you can't do that if the phone's not right beside you, and you can't press a duress alarm if that's not right beside you either. So we really had to look at how to make that more accessible. When that incident occurred, we actually had a security guard stationed in triage only a few metres away, but he did not know. So what we've been looking at is making the duresses much more available and visible. So we used to have duress alarms underneath the desks in the fishbowl, and the only time you ever set them off was accidentally via your knee. We now have them as big red buttons, and they're really obvious. We also have a lot more security staff in the ED with a bigger presence. So there's one stationed in ED all the time, but they also do rounding. We are raising the ideas of a scene controller for a code grey, so someone who's not actually in the code grey, but as a stand around to make sure that the extra people go away and aren't filming with their cameras or doing whatever they're doing or getting in the way, and also keeping the place safe. And we are applying for funding for a concept that surrounds blue light notification. So Tamworth actually presented this at a conference earlier in the year, where a blue light goes off in the area where a code grade might be, so that people don't inadvertently walk into the area. And this is a problem when people go out for x-ray and come back, or different areas of very big emergency departments. You don't necessarily know what's around the corner. We don't call code greys overhead anymore, so you need a different way of working it out. Our management post-incident has probably got a little bit of work to be done. Documentation, from my point of view, needs a big change of focus. We have very security-focused documentation at the moment via Riskman, and they do it very well. But what we don't get is the clinical indicators and the triggers. And so what we're attempting to do at Western Health is make a code grey form, similar to a code blue form, to try and capture some of the clinical data and actually see what's going on. Managing the patient after a code grey can be really problematic, especially if you've had to sedate them, and so the locations of that is a problem. But more important is what to do with the staff and the other patients and relatives afterwards. And I think finding the balance between support and then being actually able to do something is really difficult. And a lot of our staff, even with the EAPs, feel that they're not really sure what they can do. And finally, to prevention, I think the ED is ripe for stress and emotion. And some of that is due to the grief and the vulnerability and the fear of the time, and some of it is to do with not being informed of their choices or of the system. So we're trying to increase our signage and increase our communication strategies with our patients to inform them of the process. We're also getting in some kiosks that will identify GPs if they choose to go to a GP, and we're designing a video to explain the process of emergency departments. Also just improving our security cameras, our security presence, as I said, and trying to look at some distraction, so free Wi-Fi in the emergency department and things like that. All of this needs education of our staff and education of the community, and I thank WorkSafe for trying to bring that to the forefront of everyone's mind. So essentially at Western Health we're trying, I realise, to do quite a lot in this sphere at the moment. We haven't specifically addressed culture, and what I'm hoping is that with all the work that WorkSafe's been doing and all the work that we're doing in our sphere, that people will start to feel empowered and engaged, because that ultimately is my aim as an emergency physician. Acceptance is probably not the right word, but I think I need to feel responsible about the management of these patients, but not be complacent. As the director, I want everyone to be safe, but also to feel supported. But as the chair of the working party, I want people to be prepared, empowered and engaged.
Thanks, Ainsley. Well done for that presentation and the work that you're doing. We're going to move on to talk about the very topical issue of ice. I know it's something that comes up repeatedly when we talk about this issue of violence in hospitals, is the contribution that ice makes to the propensity of people to engage in violence. So I'd like to welcome Nicole Lee from 360 Edge to talk to us about this. Nicole's a director of that organisation, which is a specialist consultancy in the drug and alcohol sector, and she's also a professor at the National Drug Research Institute. And so she's going to talk to us about, on thin ice, the problem of crystal meth and how to safely and effectively respond. Thanks, Nicole.
Thanks for inviting me here today. I'm going to take a bit more, probably of a clinical approach and talk a little bit about why we might be seeing potential increases in aggression among people who use crystal meth and what we might be able to do about it. You've probably seen this little gem of an ad from the federal government a couple of years ago, and it pretty much reflects what we've seen in the media about the focus of crystal meth, particularly around the increased levels of violence among that group. And it's frightening, right? And it's scared the community significantly, so much so that now for the first time methamphetamine is the drug of most concern in the general community, despite the fact that alcohol is 10 times worse in terms of violence, aggression and harms to self and others. But also what I've noticed, I've been working with this group clinically and in research for more than 15 years, and what I've noticed is that practitioners are also scared, and as Ainsley said, when we're fearful, we don't respond very well. And so I think we need to take a little bit of heat out and figure out what's going on so that we can respond effectively. So it's a drug of most concern in the community and among practitioners, despite the fact, sorry about this messy graph, just look at the dark line. You can see that the rate of methamphetamine use in the general community has been steadily decreasing for the last 20 years. What has happened though in the last few years is that the choice of form of methamphetamine has changed. So these columns reflect the use of speed or the powdered form in the community, and among people who use meth, the preference has decreased for speed and has increased for the crystal form, which we call on the streets ice. These are exactly the same drug. If you use enough speed, you'll get the same effects as ice. They're all methamphetamine. It's a little bit like, I think of it kind of, if you think of an alcohol analogy, speed is kind of like light beer. Ice is kind of like vodka. So if you have a can of light beer, that's about one standard drink, you'd probably feel quite okay. But you wouldn't feel terribly intoxicated. But if you drank 285 mils of straight vodka, that's about 10 standard drinks, you'd probably be under the table. And that's really the difference. They look different, they taste different, they're made differently, but they're still all alcohol, same with speed and ice. So really we're talking about methamphetamine rather than ice. So we've seen a shift in the way people have used to more dangerous forms, and we've absolutely seen an increase in presentations at the clinical end and problems at the clinical end. So increases in treatment presentations, hospital separations, emergency department and ambulance call-outs. However, there's no clear causal link between using crystal meth or any other type of methamphetamine and violent behaviour. And that'll surprise many of you, I'm sure. But we don't think that acute intoxication alone is directly responsible for the violent behaviour that's been associated with methamphetamine. And it's still a relatively small proportion of the greater number of people who use methamphetamine. However, in our context, so in hospitals, in community health services, and particularly in emergency departments and mental health, we see the pointy end. We necessarily see the pointy end because that's what our jobs are. So what I want to do is just talk a little bit about why, if it's not directly to do with the drug itself, why people might become more hypersensitive and might become more aggressive and violent when they're using meth. So methamphetamine has a really complex effect on the brain. But particularly it raises the level of a number of neurochemicals. Serotonin is I'm sure you all know, is the kind of mood enhancer. It's the neurochemical that's increased when people take ecstasy. And if you've ever seen anyone on ecstasy, you're beautiful and I love you and everything's so wonderful, fabulous. And that is also increased with methamphetamine, but particularly if we're talking about aggression and violence, the two neurochemicals that are implicated are noradrenaline and dopamine. So noradrenaline is the thing that activates our fight or flight system. It increases arousal and increases energy, and so you can already see if there's an artificial increase in noradrenaline, how that's going to impact on aggression and violence. So methamphetamine, every time you use methamphetamine, you get an extra burst of noradrenaline, means that your fight or flight system is artificially switched on. And that means that things that we might not normally see as threatening become threatening. So we talk about an increase in threat sensitivity. So it doesn't directly cause violent behaviour, but it increases a sense of threat around. The other thing that it increases is the level of dopamine. You know that dopamine is the pleasure neurochemical. It's also our reward system. Every time we do something nice, you get a little burst of dopamine and it tells our brain to do it again. But the other thing about dopamine is that there's a couple of parts of our brain that need it to function well. The first part is the prefrontal cortex, or the frontal lobe, which is involved in thinking and planning and decision making. And the second part is in the centre of the brain, the limbic system, which is responsible for emotional and social processing and memories. But particularly, these are where the dopamine pathways run in the brain, directly through the prefrontal cortex, the thinking area, and the limbic system. And initially, if you take methamphetamine at low doses, those areas are enhanced, so you get extra dopamine. But if you get too much dopamine, you're using too much, or you're using over a long period of time, those systems are, they get stuffed up, basically. And they start to shut down if you're using over a long period of time. Not only do those two areas need dopamine to function, but they need to be talking to each other all the time. So you walking through a dark alley and something jumps out at you, your limbic system says, holy cow. And the prefrontal cortex then says, don't worry, just a cat, calm down. So they're doing this all of the time. But if there's no dopamine, or there's the dopamine system's out of whack, it can't do that. So you get a lot of emotional dysregulation from the limbic system. So combining those two things, you can see how threat sensitivity might be raised, and also emotion dysregulation is increased as well. The other thing about meth is that an increase in dopamine is also associated with psychotic symptoms. So if you're taking a lot of methamphetamine, you get a huge increase in dopamine. You're much more likely to have paranoia, hallucinations, delusions, a whole range of things like that. And those things are also associated with a higher level of threat sensitivity. If I'm paranoid and I think someone's spying on me, or I think someone's looking at me, I'm going to be much more hypervigilant to threat than if I didn't have that. So we've got a situation then where there's methamphetamine doesn't necessarily directly increase violence, but it increases threat sensitivity, it decreases emotional regulation, and it increases symptoms of psychosis. So you can see how all of that packaged together might be a risk factor. The thing is, I think this is quite a good thing, because it does mean that we have much more control over how people might respond. If it was just a direct relationship, there's nothing much we can do. So when I talk to people about managing aggression among meth users, you'll see this continuum. You've probably seen this before if you've had management of aggression training. Whatever you normally do with someone who's aggressive on that continuum, you would do with someone who was aggressive because they've used meth. It makes absolutely no difference why they're aggressive or violent. The reactions are going to be the same. So at this bottom end where they're kind of jittery and a bit irritated, what we're trying to do is to not make things worse. So an example of making things worse, someone who was using meth relayed a story to me of going to emergency. He said that he was feeling really paranoid, he's starting to get some psychotic symptoms. He wanted to go to someone to help him kind of calm down. He went to the emergency department and said, I'm feeling really shit, and can you just give me something to take the edge off? Of course, the emergency department has protocols, they have a triage system, they have a way of doing things, and they said, your arm's not falling off, you're not having a heart attack, so you need to go sit over there and we'll get to you in a second. And that is absolutely the right thing to do in an emergency department, but it's an aggravating thing to do if you're on meth and you're hyped up and you're ready for kind of threat, or your emotions aren't being regulated very well. So he came back a couple of times and he said, I'm really, really feeling bad now, can you just give me something to take the edge off? And they kept sending him back to the waiting area. And eventually he got really cranky and aggressive and violent, and they had to jump him with the security. So that's a situation we're kind of shoehorning, in some ways we're kind of shoehorning people who use methamphetamine and other drugs into a system that's not really designed for them. So we need to kind of think a little bit broadly about our systems and how we might be able to do some things differently in order to reduce that level of aggression and violence. I was presenting to the Consult Liaison Alcohol and Drug Nurses last week in Queensland, and one of their hospitals, it has implemented a system that I can't remember what it's called, shift, something like that, where low priority but easy, high risk, low priority, easy clients, easy patients, have a separate triage system. So people like that would just get a sedative very quickly and then get sent on their way, because that's lowered the incidence of in the ED significantly since they implemented that. So you can see these are some of the things that we say to people in terms of just talking to someone who has been using methamphetamine, and you can see they're all the things that you already know how to do. So again, what I want to say to you is that all of the management of aggression training that you've had and any responses that you have with people with methamphetamine are exactly the same as our responses for anyone else who's aggressive or violent. Sorry, and I would just go back to this thing here. I didn't finish half of this sentence, but in jittery and irritated, we're trying to not make things worse. Around the middle area where people are starting to get angry, we're trying to de-escalate and use all the same de-escalation skills that we use for other people. And then when people are physically aggressive and violent, we're implementing our safety measures exactly the same way. One of the things that I've noticed is two things among practitioners who are responding. We can make things worse if we're fearful and we respond aggressively ourselves or in a defensive way, and often it's because we are taking things personally, but we have to understand that brain functioning is not that great, and they might have drugs on board, and they may not be rational and may not be responding in a rational way. And this is a quote from Marsha Linehan, who developed dialectical behaviour therapy for borderline personality disorder, but I like to think about this for everybody when I respond to everybody in the community and my clients, is that really people get aggressive because their needs aren't being met. They might not be the needs things that we think they need, but ultimately everybody is doing the best they can in that moment. And if they could do better, they absolutely would. And that helps me to kind of step back and not respond in an ineffective way. I want to just note, can I do an ad? Is that okay? Yeah. We've been contracted among a whole lot of other providers, but we have the broader health sector to provide ICE training for frontline workers. They're half-day training sessions, and if you go to our website, which is not on there, it's www.360edge.com.au, you will see all of the sessions across the state for half-day training on managing responding to ICE use if you're interested in that. Thank you.
Thank you, Nicole. There's lots of aspects of those drugs that we don't know about, so that was really interesting and informative. And I'm advised to tell you that that training is funded. It's free, basically. So there's an opportunity there across the health system, and the department's looking after that. Okay, we're going to go on to hear about patient safety as a foundation for staff safety, and we've got 3 presenters from the Office of the Chief Mental Health Nurse at the Department of Health. So we've got Indigo Daya, who is a Senior Consumer Advisor in that office, and we've also got Rachel Gwitham, and Lisa Spong, and Rachel and Lisa are both Senior Project Officers. So I'd like to invite all of you to come forward. I'm not sure how you're going to organise this, but come on forward, and for those of you who aren't presenting, feel free perhaps to take some seats over here.
Thank you very much. Hi everyone. I'm aware we're getting closer to lunch, so I hope people will be tolerant with us and be able to stay focused. My name's Indigo, Rachel and Lisa. So we've split our presentation today up into 3 sections, so you'll get to hear a bit from each of us, but you're stuck with me first, so that could be good or bad, but we'll see how it goes. And just so people, we have quite commonly employ consumers to be a part of mental health service delivery, but also work with policy in the department. But I'm not sure that happens so often in other parts of health. So if people aren't aware, that's what it sort of means to be a senior consumer advisor. So, hello. So I'm someone who spent many years in and out of psychiatric hospital as a consumer a number of years back, but off and on for about 9 years. I had, you don't need to know my whole story, but I had diagnoses of schizophrenia and borderline, amongst others, and variable experiences, which if we have time, I'll tell you a snippet about towards the end. But these days I use my lived experiences and also my connection with many other consumers and patients to inform how we think about policy and service delivery. So it's quite a privilege to be able to work in that way. So that's what that's about. So our presentation is split into 3. The first section I'll talk with you about is what do safe wards have to do with the subject of today, which is occupational violence. Rachel will talk with us some more about what safe wards actually is, what it's all about. And then Lisa's going to share some practical strategies that we hope people can take away with them from today and back to your different workplaces. So that's now which button do you reckon? This one? No, that one. Press them all, said Lisa. I'm normally good at pressing people's buttons, but... So how does safe wards relate to occupational violence? Something that's really central to safe wards is that it's about safety for both staff and patients, which is something I probably quite obviously particularly like about this model, that it requires us to think about everyone together, which is part of our title for today, that we are in this together. And so the way that it does that, if we look at the, I'll just press that button too, the foundations of the research that led to the development of the safe wards model looked at the relationship between 2 different things. If we read the safe wards literature, the terminology used is conflict and containment. But for the purposes of today, we've put up there occupational violence and restrictive practice, which is close enough to the definitions of what these things mean. If you dive into safe wards, conflict includes more than occupational violence. It's anything that's actual harm or that carries the risk of harm. So it could include verbal or physical aggression or property damage, or people absconding, which I should confess, although I'm not sure it's the right audience, I'll see if I get a laugh, but I was a serial and quite expert absconder from services. I got a laugh, that's good, in my day. And I don't share my secrets about how I did it. thankfully that didn't lead to harm. But today's about occupational violence, but what Safe Wards tells us is that these two things have a relationship with each other. So restrictive practices used for patients relate to occupational violence experienced by staff. And so if we move on to, it's this button, isn't it? This next slide. This is sort of a different way for us to think about that same subject. So what we've got here, and in the middle we've talked about cultures of control. Now mental health is different to other parts of health. We have a Mental Health Act that allows space for compulsory detention and treatment, which is in many ways different to other parts of health, but I think that restriction still happens in all parts of health in different ways, so I hope this still feels relevant. And what we see, if I do this, can you guys, no you can't see the little arrow, that's okay. If we start up the top, we see here restrictive interventions. Imagine that's where we begin on this cycle. That a restrictive intervention, which in mental health, but potentially in other parts of health as well, is something that's done to control a person. So we might see the use of seclusion room or restraints. We might see special observations. There could be a whole range of things that are done to control that person. Now, a natural reaction to being controlled, which is not something that just patients have, but actually anyone, is to be fearful when we're controlled, yeah? So people feel afraid of that, and we've got three big responses, three things we can do when we're fearful that are sort of innate in us. We can fight, we can flee and get out of there, or we can freeze like a deer in the headlights. One of the issues we've got, particularly in mental health units, is that it's very hard to flee when the unit's locked. You could be a skillful absconder like me, and people do abscond, but it's difficult to flee. So one of those natural reactions to if you don't feel safe isn't there. And that could be quite true as well in other places. If you feel frightened in an emergency department, is it that easy to get out if you feel the need to get out? And to freeze can also present problems. If people have that freeze reaction, that may be seen as a worsening of mental health, which might lead to more restrictive interventions anyway. So there's kind of a loop. So in some ways, what we do in services is increase the likelihood of a fight reaction because flee and freeze are taken off us. So greater likelihood of fight, and what does that lead to, of course, down the bottom of the cycle? Occupational violence. And then what we see coming out the other side is the exact same thing for staff as we saw for patients. How do the staff feel? Afraid. And what are our options? Can you go running out of the service? Well, you can, I guess. So, you know, you've got a swipe pass for the door, which is something we don't usually have as a patient. But that's not really an option, is it? If this is your career, this is your job, and you're there trying to make a difference. Freeze is also really difficult, although we see that as well. We see many health workers develop all sorts of burnout, compassion fatigue, sick leave. And I think sometimes we do see things like flight. If we see a sort of mass exodus of staff to the nurses' station, or the fishbowl is kind of another kind of flight, perhaps too. But actually fight is left as potentially the more likely option there as well. And so what do we do when we're fighting, we're trying to get control? More restrictive interventions. And so it's not in reality as simple as this, but what this tells us is that there is a relationship between these things, and this can be a very difficult cycle to get out of, and it's not helpful for staff and it's not helpful for patients. So what we get with Safe Wards is, I guess, a model that asks us to think differently, to step out of that cycle, and it gives us a framework of understanding what's actually happening in services and for people using services, and it gives us a lot of practical strategies or interventions to use to set up a different kind of culture, a sort of culture that's focused on care, or we might call it a Safe Wards culture. And so rather than restrictive interventions, our absolute focus is how do we pull back to a therapeutic intervention? What can we do in this moment that's going to be most helpful for everyone, and that's also going to keep everyone safe? If we do that, we have patients that feel safe, who are then going to be more likely to trust and hope that something positive comes out of this. Down the bottom, we're more likely to see a positive connection and understanding, which means what? Staff are going to feel safe if people are connecting and being understanding, and we continue that cycle of trust. Again, it's not quite so simple in the real world, but it's a very different kind of model that can take us to very different and much more positive places. So before I finish up and hand over to Rachel to take you through the more practicalities of what the model looks like, and Lisa will share some of the interventions as well, I just wanted to share something a bit personal. It's what we often like to do, those of us who work in consumer roles, but I guess it's feels like an important reflection to make given the subject today. And I wanted to start, I guess, it's interesting, as someone, particularly someone who's been diagnosed with schizophrenia, a lot of people don't realise how common experiences of trauma and child abuse can be amongst those of us who end up in health services, and particularly mental health services. But it's actually incredibly common, so more than 85% of us have a history of violence in our childhoods. And I'm also a child who experienced quite significant, I'm not a child now, I was a child, who experienced significant neglect and violence and abuse. So this subject touches me quite profoundly and in a whole lot of different ways, what we're talking about today. But when I was a child, at the age of 13, I was abducted. And I'm not going to go into the details of that because it's horrible, and we've sort of heard a lot of triggering horrible things today. I don't want to add to that. But it was quite horrific, and I want you to think about this short description. Strangers come into my home and they take me away. I don't want to go with them, but they make me. And they take me to a strange place, and I'm locked in there. And there's locks on locks on locks, and I have to take all my clothes off. And I'm really scared and I'm cold. And then they make me take substances, and I don't know what's happening to me. And I've never been so terrified. And I often share this, and I ask people to think about what I'm describing, because I'm describing two things. I'm describing my abduction as a child, but I'm also describing my last admission to a psychiatric unit, because that was what happened. And I share it very specifically to remind us about the things that can sometimes lead to challenging behaviours, difficult behaviours, but actually quite understandable behaviours if we know a person's story. That when I'm unwell, like many of my fellow consumers, I'm usually reliving the worst, most terrifying experiences of my life. And it looks and sounds really strange to other people, I do understand that, but what's going on is nightmarish stuff inside my head. And I think we have a problem when the services that are there to help and the people that want to help actually play a role in recreating the worst nightmare of my life, in offering that help. And I think I share that because I hope it goes some way towards helping to understand why sometimes we do what we do when we turn up to services, why we try very hard to get away from the police, because I've been in a divvy van too, or very hard to get away from the ambulance officers or the emergency department. So I share that, and I guess I share it because this is common for many consumers. I share it because I think today's really important. I absolutely agree that violence is not okay. I think it is not okay that health workers don't feel safe and aren't safe at work, but I also think that patients should be safe as well. And I guess there's a part of this conversation that can easily be missing when we think about occupational violence, is violence that's experienced by the people who use our sector. And I guess what I really love about Safe Wards is that it reminds us that we are in it together, and that one of the best routes for everyone to be safe is for everyone to be safe. And when we think about safety, that we think about the safety of everyone together. So, sorry my voice got a bit wobbly, it's quite a personal thing to share, but I want to hand over to Rachel, who's going to give you proper scientific stuff about the model and won't be so awkward. But thank you.
Thanks, Indy. Going to obviously be quite difficult to follow on from that. Can I just get a show of hands of who's heard of Safe Wards before, knows a little bit about it? Great. Most of you. That's fantastic. So this might be a refresher for some of you. So just in way of background, a bit of the basics really around Safe Wards. It's a model It came from the UK. There's a lot of research behind the model. Professor Len Bowers, who is in charge of putting the model together, has done a lot of his own research, over 20 years worth of research, trying to understand what makes psychiatric units particularly unsafe, what some of the events are, how and when they happen. He also looked at extensive research that was done in this space by others, nearly 1,200 articles that was trying to understand the complexities of inpatient units, predominantly in and around the UK, but he did look a bit broader, and then tried to make sense of that and put it into a nice, neat package that people on the ground could actually understand and work with, and try and create safer spaces both for the people that we work for, but also for the staff as well. So there's a solid evidence behind it in trying to understand the conflict, as Indy was talking about. So there are all those events that potentially might lead to risks for the patients, but also for the staff, and to understand those things that staff may do in response to that can also increase the risk of further harm, both again for the patients and for the staff. So trying to understand the relationship between those two things. This was something that was introduced here in Victoria, and some of you here were involved in a trial that was conducted in 7 health services in 2014 and 15. That was introduced into 18 inpatient units across the state. We introduced the model as well as the 10 interventions, which I will talk a little bit about. And part of that evaluation here in Victoria found that it also had applicability in mental health settings in a Victorian context, as well as broader applicability. So not just in adult acute inpatient settings, which is where the research comes from, but also in extended care units, aged acute units, adolescent and youth settings as well. So a lot broader than just adult settings. We are now in a new phase of safe wards, and we are now introducing it, in the process of introducing it into all mental health inpatient units across the state. So we've done train-the-trainer sessions in 8 services so far across the state, and we're engaging with services around both training and implementation of this model. Obviously, we see broader application across the state. The next phase, which will be happening at the end of next year, will be looking at introducing it into the emergency departments and into general settings. And there already has been some work that's been happening across the state in these areas. It's being piloted in Peninsula and La Trobe as well, to see what adaptations might be necessary in other health settings. But most people, when they understand the model, can definitely see how it would fit in a broader health context. So that's just a bit of the background. The model essentially looks a little bit like this. The model is looking at features of an inpatient unit that could potentially increase the likelihood of those behaviours that could cause risk to patients and staff. And so there's 6 areas, as you can see there. So it looks at things such as what the staff bring to the situation, what's happening for the patients themselves, how patients are interacting with each other, the physical environment, the rules and regulations that are going to impact on the patients as well, and the things that are happening for people outside of the hospital environment. As well as the model, and in understanding that, there's also a set of 10 interventions, which was part of a trial in the UK. We also trialled that in Victoria, and we've been using these 10 particular interventions to try and address some of the risk factors that can come from inpatient settings. So that's the model very briefly. Just to explain, I guess, the process and how it works a little bit, you'll notice here that there's 4 boxes along the bottom, and that's really depicting a chain of events that we know occurs in inpatient settings. So on the left, you'll see the originating domains, which is those 6 features that I mentioned before that make up an inpatient setting that could potentially lead to flashpoints. And flashpoints are essentially triggers that can arise from those features of an inpatient setting that may then very quickly turn into a conflict event. The conflict event can often then lead to containment, which is anything that could be restrictive, and obviously Indy's already mentioned some examples of those. And what we need to recognise is the relationship between the conflict event and the containment, because there's always a real risk that when we're using restrictive interventions, we're going to see an increase in that conflict behaviour. So the model is trying to help us understand what's happening, when it's happening and how it's happening, and then trying to think about how we could be more proactive in reducing the likelihood of that conflict behaviour. So you'll notice the staff modifiers, and it's really identifying all along that chain of events opportunities where we can actually intervene. Some of the interventions are particularly relevant at certain points along this chain of events, which I'll just quickly outline because I don't have a lot of time left. In terms of the originating domains and being a lot more proactive and trying to lay a good foundation for connection and that therapeutic relationship, know each other is a nice way of doing that, where we're sharing a bit about each other and trying to build rapport and common humanity. Clear expectations is where everyone on the unit, both staff and patients, come together with an agreed list of expectations that's trying to make building that relationship a lot easier and spending time together, which is more of a trying to redress that power imbalance that we know happens on our units. Positive words is particularly around handover, and that's trying to understand what's happening for the person, what is contributing to the behaviours that we're seeing, and how can we work with that, what's a helpful strategy. So they're a bit more around prevention. If we are seeing opportunities for patients to modify what's happening in terms of how they support each other, these interventions, particularly discharge messages and mutual help meeting, are a really lovely way of doing that, both by patients leaving messages for other patients, but also supporting each other in a group setting and using the opportunities to connect with each other in a positive way. If we are likely to see flashpoints or triggers that arise from what's happening in our environments, these interventions can be really helpful. So it's around how we debrief our consumers after an incident, so we don't see further incidents as a consequence of that. Bad news mitigation is thinking about how we plan for either delivering bad news if it's something that we're involved in, or being responsive when someone receives bad news, and ensuring that we're not going to see further conflict as a result of that. And softwares is thinking about when we need to set limits, actually thinking about, do we need to set this limit, how are we going to set this limit, and what supports we're going to put in place for the person. And a bit further along the chain of events, sometimes we need to engage a bit more assertively around using de-escalation skills with the person. So talk down is a process of de-escalation, which is trying to focus on being respectful and empathetic, and calm down methods is some items that are assisting somebody to self-regulate in those situations where it might be quite difficult using sensory items. So they're the interventions, and I'm going to pass you on to Lisa to give you some more practical tips.
My heart's jumping out of my chest, and I don't know why, because I actually love attention. I love talking in front of people, so maybe if you smiled a bit more at me, I might be okay. I'm also aware that I'm about to sell you an apple when you're holding a chocolate bar prior to lunch. So just be aware that, yeah, that helped, 5 minutes. So just be aware that when we train with these interventions, that we can do this in 3 full days. And I've got 5 minutes, so I'm going to highlight 3. And be kind. And I'm very grateful that we've followed Dr. Nicole Lee, because one of the interventions is about positive words, and it is about having psychological understanding of what is occurring. So that's one thing I'm grateful for Dr. Nicole Lee, and the other thing is that she's opened up the door to be able to say holy shit cow. So these are the 3 interventions that I'm going to briefly talk about. Along that spectrum that Rachel showed, which is the originating domains, flashpoints, or some people might be more familiar with the term triggers, and conflict. So positive words, these 3 interventions I think are quite potential to OVA. Starting with positive words, which is a focus on more of the prevention. So typically positive words does target clinical handover, and it identifies language, attitude and culture, not just individually but in the workplace as well. Soft words is an intervention about setting limits, which I'm sure a lot of people here would agree can be a very tough thing to do, and can often be the pivot point of where things can start to go wrong. And talk down, which is a de-escalation model for a process during a conflict.
And I think especially people that do a lot of reviewing of incidents of occupational violence and aggression, a lot of documentation will say the situation escalated, so de-escalation was required, and that doesn't help a lot because I don't know what that means, unless it's about riding up and down stairs that don't move, which we love because that takes less stress. But de-escalation sometimes doesn't mean a lot to a lot of people, especially if you're a new clinician or a healthcare professional. Does everyone agree with that? Thank you. The first intervention, positive words. Our brains see negative and positive information very differently. And generally, we just reflect on the negative, and the language around that can be very strong, more so than positive. So you really can set a tone for a shift when you're using negative language, and particularly when it is around challenging behaviours and things, you do tend to think that you're handing over a risk, of what you're actually doing is setting a real tone for negativity. And so positive words is about turning that around, identifying the language we use and how, as strongly as negative language can work, positive language can work just as strongly. And it's such an obvious thing to see, particularly in your workplace with culture and attitude. And if we... Oh, I've gone... My mouth's so dry, it's just ridiculous. That's okay, it's playing into my whole attention thing here. So positive language, setting the tone. If you have a positive mindset, you will approach an incident in a more positive manner. Soft words. Oh, that's okay, it'll just end up going on there. Soft words, this intervention aims to expand skills and choices for staff when you're setting limits. There's a lot of tips and tools that can be used in this intervention, and the training around it's really important. It is a means of reminding staff to always use the best style of communication in difficult situations. I think that's really important. If you think about setting a limit, particularly around the common thing at the moment, or has been for a little while, is no smoking and things like that. Often your clinicians or staff, all staff, have to sort of deliver that message, and it can be a real tough one. It can be a real point where things can go quite awful. And then what's the organisation's expectations if that person, are you then to become an enforcer, or are you actually just providing advice, education and some assistance to that person? So soft words certainly is about, do you have to set really hard limits? Can you say yes? Can you say yes sometimes? How do you react when others set limits on you? Yeah. Think about that. So talk down. This is a really important model, and we do love this because it is a process. And I think that a lot of people here would identify really strongly with, probably even from a young age or school age, DR ABC. It's sort of like this thing, isn't it, that you would know what that was if I said to you, what's Dr. ABC? Danger, response. Yep. So talk down can be about having that process locked in as well, so that when you're approaching a situation that can be confronting and aggressive, am I going too far over? No. That you think of this process: delimit, clarify, resolve. So if you've got nothing else and all sensibilities start to flat, take a few deep breaths, remain in control, remain empathetic and respectful. And if you can do that, and you can think of these 3 arrows, we might get through this situation okay. So delimit, which is exactly what that is. Am I in the safest place to be able to start this process of de-escalation? Do I need some people to be removed? Are all the people aware that need to be, that I'm approaching this situation? I think the most important thing we often miss, I will speak for myself actually, is clarifying. So I think sometimes we go from, this is a situation, I've made it safe, now I just need to resolve this so we can all get through it safely. But we forget to ask the middle bit, which is, what is it that you need? I'm going to clarify the situation here. What is it that you want? And can I help you with that? It's also about recognising with that person and reminding them of the relationship that we have, reminding them that no one wants to get hurt, so let's get through this. And these arrows can be a bit interchangeable sometimes. And then the last thing is resolve. Can I actually offer what this person wants in a nice manner, or at least support or offer some alternatives? So that's what this model of de-escalation is, and I think it's really important, especially for beginning practitioners. And like I said, it will only succeed if you remain in control and express respect and empathy at all times. I got through it. Okay. You would be surprised. I normally love doing this stuff. I'm really scared of you guys. Thank you. There is a website, and I really encourage you to get on it. We've got all this information on there about safe wards. It's all free. Go and have a look at it. There's some really cool videos on there of Rachel, and lots of resources, lots of great posters with things like these models, and goes into much, much greater detail. So thank you for accepting the apple when you had the chocolate bar in your hand.
Well done, ladies. Thank you. That was interesting and entertaining, so and very informative. And so thank you to all, and Indigo, thank you very much indeed, particularly for sharing your some of your personal experiences with us. That was really engaging for people, I'm sure. We've got our final presenter before we do our little panel session before lunch. Our next presenter is Neil Turton-Lane, and Neil is from the Victorian Mental Illness Awareness Council. He's the Acting Chief Executive Officer, and he is going to talk to us about consumer perspectives and safety being important for everyone. So welcome, Neil.
Sorry, I've just got to get some water. Okay, hi, my name's Neil Turton-Lane. I hope you're all travelling well today and you've had a chance to recover from what was a very sad moment this morning when we started this forum. And thank you, Lisa, Indy and Rachel, for that great talk on safe wards. While I was waiting to come up, I was practicing some of those techniques on myself, and I can tell you they work really well. Okay, a little bit about myself. I am acting CEO of VMIAC for another week, when I'll very gratefully hand that role back to Maggie Toko, and won't go there again, I can promise you that. I also have a diagnosis of schizophrenia, and I've spent a couple of years of my life living on psych wards. I'm also, like Indy, a victim of childhood sexual abuse and other traumas, and that's part of what I carry with me. Yeah, so I might just move on now. How do you? Down arrow. Where the goddamn hell is that? All right, thank you. Okay, all right. So a little bit about VMIAC. We're the peak NGO representing consumers in Victoria, and that encompasses a lot of people with different takes on what mental illness is, or mental health concerns are. We provide advocacy for people right across the state, and we deliver training and information to people and the community. We have a large membership base. I think we've got 1,300 members. Is that large? It sounds kind of a bit large, but it's large to me anyway. And we are staffed and led by people with a lived experience of mental illness. And we're in East Brunswick if you ever want to pop by. It's a very friendly place. Okay, so my talk today is about safety is important for everyone, and I just want to begin by saying, that this whole conversation this morning, the WorkSafe ads, that it's very important that we're at this position in time, and that we're starting to look at violence in healthcare settings, because it's completely unacceptable for violence to occur in a place where people go, for help and support. And the impact of violence on people is so tremendous. As someone myself who has been kind of subject to a couple of serious violent assaults, I kind of know it's something that you don't really get over. It kind of stays with you for a lifetime. No one should have to turn up to work feeling unsafe, and that's the case for a lot of people in the health system. I've worked in the health system for nearly 20 years, and I've been involved in a lot of incidents. I've seen lots of lockdowns, and I've worked 10 of those years in Footscray and seen some very kind of violent things happening in Footscray. And last but not least, no patient should ever have to experience violence in a healthcare setting. And unfortunately, that does happen. So what I'm going to cover today is just the whole challenging context of this conversation about violence in healthcare settings. I think everyone here is aware of that. It is challenging, extremely challenging, and as someone who's been on both sides of the fence, as a worker and a patient, so that's really driven home to me a lot. And I'm going to talk about some things that I think that need to change, and that's just not change within health systems. It's broader than that, and also share some kind of concerns I have for what's happening in mental health, or what needs to happen in mental health. All right, so I'll begin by saying we need to have a conversation. Actually, we need to have a dialogue, and it needs to be inclusive, and it needs to really make clear that violence and aggression, it isn't a us and them thing. It's not something that one person wears and the other person feels the force of. It's more complex than that. We also need to have that conversation, so we don't further stigmatise already kind of damaged and marginalised people who come for us seeking kind of help. And I think most importantly that we need to recognise that the root cause of violence is anger, and as a culture, we're awash with anger, and it's running amok, and it's a major social issue for us all, and it's not something that's really being addressed out there. We're seeing it in the health system, but it's happening everywhere. It's in schools, teachers, everywhere you name it, public transport. It's just out there, and it's anger, and it's uncontrolled anger, and surely there must be a way of supporting people to learn really a little bit more about how to manage the feelings that they're having. And finally, we need to have that conversation about the failings in our current system and what needs to change and how we're going to go about doing that. Well, I'm glad someone laughed, I don't think it's funny, really, but, no, but, there is a real danger if we have a one-sided conversation, and we've had some very good examples of late about that. Okay, all right, just moving along. I'm going to talk about the mental health system because that's what I work in, and these facts and figures, they're taken from the the Mental Health Services annual report from last year. And, you know, and you can see like there's, you know, like 67,000 people using clinical services. I think that's kind of like stayed about that number for quite a few years, but with nearly 20,000 hospitalisations of adults with a mental illness in inpatient wards. Half of those are involuntary, and you know, so it's a case where people don't have a choice whether they're going to be treated or not. And you know, like, and as noted in the report, there's real concerns that you know that admissions are kind of like increasing, kind of like even more, particularly in some areas, the outer eastern areas, where there's just been this huge surge, and there's questions about why that's happening. You know, is it you know, the obvious one? Is it drugs, or is it something else, or is it just the whole combination of what's happening for people? Okay, and this is a little graphic that looks at you know, the source of referrals. So it's referrals, but it also gives you some understanding, you know, that just how many kind of like presentations are taking place at EDs. Also, it's got some figures around, you know, bodily restraint, and bodily restraint is a whole lot of things now. You know, and they're quite concerning that that's happening at such a rate. Seclusion, again, you know, it hasn't changed much. It's changed a little. It's dropped, I think, 1 percentage point since there was that move towards kind of like, you know, getting rid of, you know, such restrictive interventions. Again, someone who has been secluded a number of times, I can tell you how terrifying it is, because you've got absolutely no, you know, understanding what's happening next, or, and all right, so here's a little bit of research that's been pulled together, and sort of just thought, I suppose, allows people to look at sort of like just who's coming to hospital, and perhaps what some of those people's backgrounds are, and you know, and they're, you know, they're often very significant backgrounds of trauma, violence, family violence, emotional abuse, you know, and having those kind of backgrounds means that, you know, the potential for you to get really ill quite a lot, you know, just magnifies like out of hand. You know, and you know, the really sad thing is, you know, like a lot of this trauma and experiences that people have then gets replayed in hospitals, because, I mean, putting people into hospitals altogether in a very overcrowded mental health system, it's just, and, you know, for a lot of people it's the worst thing. You know, a lot of people are just traumatised by their hospitalisations, and they take a long time to get over, and I'm not saying there's not a need for intervention, so I just kind of question the wisdom that this is all we've got at the moment. So this is my final slide, and it's just some parting thoughts. And unintentionally, I've left out a word there, but as someone pointed out, how do we talk about this without talking about this or this? And I think, you know, it's a big question. I suppose it's just, for me anyway, it sums up the whole thing. You know, how do we have this conversation about violence and aggression, what we're going to do in healthcare to make people safer, to make patients safer, and and most importantly, to make staff who turn up every day to do this job safe. And I don't know the answer, but I feel that it's something that will come out of people with a lived experience of mental illness, drug use, mental health staff, hospital staff, getting together and talking and understanding what's happening for each other a little bit more, having a better understanding of what's happening in those spaces. Okay, all right, thank you.
Thanks, Neil, very much indeed for, again, that very thought-provoking presentation. Now we're going to move into a question session before lunch, and I have got a couple of questions just to kick things off. The way this will operate is that we have our presenters from this past session. We can't actually fit them all up here on the panel, so they're all going to sit here and look at me, and Tanya's going to pass the microphone around between them so that they can respond to your questions. So if you've got a question, come and stand up at one of the mics and be prepared to put it forward. I'll kick off with a couple of questions that we've received from our video conferencing participants. This one really relates to the first session, but it's from Narelle from SCHS, which I think might be Southern Community Health Service perhaps. And she's asked, is the round three for funding through the Health Service Violence Prevention Program open? And the answer to that is yes, it is. It's open from now until the end of July. And there's a link on the department's website through the Worker Health and Wellbeing page, or I've got through Health Facility Design in the Worker Health and Wellbeing page of the department's website. And if you'd like more information about that, Janelle can give that to you over lunchtime, but it is a $20 million fund. $7 million available this year for capital infrastructure purposes. So there's an opportunity. Let's go to our first question over on my left. Would you like to kick off? Just introduce who you are.
Thank you. My name's Clark Martin. I don't actually work in health, I work in disability, but it's been a fantastic morning, and you know, can't help but congratulate all those people who've put together the awareness programs and the pre-work that's led up to it. However, my question is to Elise Sens, the doctor at Footscray and Sunshine ED departments, where quite concerning, she's raised this issue that staff have become sceptical and angry, and I think I've reflected on that, and I think we all feel, you know, in a bit of state of shock that Victoria's lost a surgeon this week. And I reflect back and seeing other major, I remember when David Hooks was killed at a hotel, and the state virtually overnight changed. They brought new crowd controlling rules in, and there hasn't been another major incident on a door since then. I can also reflect on recent work where we've seen a car go up Burke Street, and instantaneously the whole city's been laid out with bollards.
Just to make sure we have enough time for everyone to ask their question.
So my question is that
in
the doctor's presentation, she did mention quite significant control. She mentioned bodyguards, she mentioned the glass bowl, and other quite high order hierarchy controls. I'm asking the doc, she's the chair of that committee. Yep. Are they considering a higher order control since the death of a surgeon in Victoria?
Ainsley, thank you. Would you like to stand up perhaps and turn around?
Thank you for that really challenging question. I'm just going to stand up a little bit higher, I'm sorry. I think it's really hard, and I'm probably going to stumble with some words here because I think there's several different issues going on here. There's violence in the workplace which is not related to people's actual work at the time, and I think that the neurosurgeon case with that, he was in the foyer, and the case of the surgeon recently, he was actually in the foyer or the lift bay as well. And I think that the violence that we see in terms of random acts of violence and unexplained and unwanted and unwarranted acts of violence is completely separate to the clinical aggression that we're talking about that we also see and have to manage. So balancing those is really hard, because if we wall up our emergency department, for example, and create a massive distance between our patients and our nurses and our doctors. We will not be able to do our job, and we'll actually create more barriers in the environment and more angst. So if you look around the way that emergency departments are being designed, they're actually reducing those barriers. They're making less walls between patients and the healthcare staff to try and make it a more caring environment. So I think it's a lot harder than having just a very quick response, and there's lots of different factors. So I noticed that you mentioned that in other disciplines we come to a very quick decision on how we're going to manage it. It definitely doesn't happen that easily in healthcare because we're actually managing clinical aggression, which is appropriate for us to manage in a different way.
Thanks, Ainsley, very much indeed. Now, while we're waiting for any other questions from the room here, we've got a question from, it's a question that's directed to Nicole. And the question is again from our video conference participants. As an ED nurse, I personally feel that we are or may be overutilising ketamine in managing patients with drug-induced aggression. Same goes with unnecessarily applying restrictive or forceful approaches in attending to that category of patients. Using ketamine for a patient on 2 consecutive occasions could be leading to taking ketamine again on other occasions. What's your view about this observation? Is that something you're comfortable responding to?
Yes.
Yeah, and Ainsley may even wish to have a response to that as well. Yeah.
Just reminding everyone that I'm a psychologist and not a nurse or a doctor. There are ketamine's not a particularly evidence-based restraint for people with behavioural disorders in emergency, but there are several protocols that have been tested. Droperidol and haloperidol are the preferred sedatives in that environment, and I can send Tanya or someone the protocols if anyone wants to access them. They're publicly available but I think one of the things to remember is that there's a continuum of aggression, and if it does get to that point, you should absolutely use chemical restraint, but hopefully you could prevent that much earlier than having to do that, and that should be really the final point. Not kind of your first line action.
Thank you. Anyone else like to make a comment about that? Yes, thank you. Would you just perhaps stand up and introduce yourself? Thanks.
My name is Daniel Eltringham. I'm a Drug and Alcohol Care Coordinator, and I work in the Emergency Department in Bendigo. We've developed guidelines on management of acute behavioural disturbance. The side I took was sort of around the strategies and how we approach a situation, sort of from an aggression management sort of point of view, and how we work together. I also worked with one of our consultants around appropriate sedation guidelines and that sort of stuff. And the way I look at it, and I think this is sort of different to the way that a lot of people look at it, you're not just managing the behaviour, you're not managing the violence, you're managing the person who is overstimulated, who has taken, in some cases, way too much methamphetamine. There's actually a whole heap of health impacts of that. So you're not just sedating the behaviour, not making it safe for the staff around, you're actually making it safe for the patient, and you're actually treating the patient in that overstimulation from those amphetamines. So I think it's really important to actually, when you're looking at things like chemical sedation, when you're looking at things like mechanical restraint, to actually look at the reason why you're using them. And it's not just about that control of the behaviour, it's about actually providing treatment, about providing safety for that person.
Well, thank you for that comment very much. I can see Ainsley nodding down here. There are no statewide guidelines for this, and the question was raised earlier about statewide guidelines for physical restraint as well.
So there are no statewide guidelines about the chemical restraint in Victoria. There are statewide guidelines in New South Wales.
Right.
And my point, I would agree that ketamine is not first line for management of acute behavioural disturbance. It's probably fourth line, maybe fifth line. And that it's only used at the moment in the situations where control is nowhere near gained, and that safety for both the patient and staff, etc., is paramount. And so the Ambulance Victoria are using it as their third or fourth line in the back of an ambulance, or about to try and get into the back of an ambulance where safety is a big issue.
And the element of this question that says using ketamine for a patient on 2 consecutive occasions could be leading to taking ketamine again on other occasions. Would anyone like to comment on that? Ainsley, thank you.
Ketamine is used as a recreational drug, as most of you know, but there's no evidence that if you give any kind of opiates or ketamine or anything to someone once or twice in small doses, in clinical doses, that it will lead to dependence or anything like that. So in that sense, it's a reasonable response if that's what's required.
If it's the required response, it's reasonable. Okay, thank you. Down the front here, we have a question.
Comment more than a question, and it's in line with safe wards and the use of words and that.
Would you like to just introduce yourself?
Oh, Nino De Pasquale, a senior psychiatric nurse from Mercy Mental Health. A few times now I've just heard chemical restraint used rather than chemical intervention in the nature of treatment, and also that, you know, we're actually treating people. Let's actually consider the language and the use of the language. I'm sure if we're said to a person who's just come out of being medicated heavily for amphetamine use or psychosis or whatever it means, if we actually said to them we've used chemical restraint rather than chemical intervention or chemical treatment, they'll view that in a negative way. So just a word thing.
Okay, that's a really good point, isn't it? So are there many, thank you, you've got a few people agreeing with that. Are there many language issues around this issue that need to be resolved? A lot. Is there? Yeah, okay, good point. Thanks for that very much. I'll just, we'll come on to this question here as well, thanks.
Yeah, hi, Derek McHugh from St Vincent's. One of the things we haven't heard anything about today is effectively treating nicotine withdrawal.
Treating what withdrawal?
Nicotine.
Nicotine withdrawal, thank you, yes.
The use of NRT throughout medical boards and in emergency departments. Hospitals are all no smoking zones, and there's a whole bunch of other stuff about how effectively that's being enforced. But we need to be providing effective NRT for people while they're waiting in waiting rooms and becoming more irritable as they're going into withdrawals. We need to be looking at putting patches on people after we've had to sedate them, because then they're coming out of the sedation, they're in withdrawal, and we're really not getting ahead of the curve on that one at the moment.
Okay, thanks for that point. People agree with that we've got work to do on nicotine replacement, that's a cause of an escalation of aggression in some patients. Okay, are there examples of good practice, or are we struggling across the system with that? Hands up, down, yep. Just grab the mic if you don't mind, thanks.
Also, a part of my role, I've developed withdrawal guidelines for our hospital, and I think it's withdrawal in general.
Right.
The number of times you'll hear code grey in medical, code grey in medical, code grey in medical, then I actually get a referral for that person, because I cover all of the hospital, and that person has been using amphetamines, they're in alcohol withdrawal, they use some drug and they haven't identified it at the right point, and they haven't instituted effective strategies to actually manage that withdrawal. Yep. So I think that's a large cause of aggression that's actually not well managed in a lot of health settings.
Okay, thanks for that comment very much. I'll just give you another question that's come from our regional colleagues. In the context of the principle dolus eventualis, I should know what that means, and I don't, but I think it means taking responsibility for actions from the... I'll continue to read the question. What new strategies or measures are in progress to let the perpetrators of violence face the consequences of their actions? I believe changes could be achieved when people are aware of or have suffered in the past the consequences of their actions. And the answer that I've been given by Janelle is that in 2014 there was a change in state legislation to increase penalties for assaults against healthcare workers, and the department is working with the Department of Justice at the moment to understand the impact and the use of that legislative change since 2014. So there was change to increase, justice responses to assaults, and it's being evaluated. Yes, please, just grab the mic if you don't mind. Or if you hop up and stand there, that'd be great.
Sorry, I just have to comment on that one point with regards to it. We often struggle with neurosurgery in particular because we see a lot of brain injury, and a lot of people nowadays, they survive brain injuries. If they're in close enough proximity, and in fact ambulance services improved to such a degree that they're almost always close enough to us, we can do life-saving surgery. The problem is with life-saving surgery and a great ICU is that the outcome is not necessarily what you would wish for.
Mm-hmm.
And the problem with outcome and legislation is that to potentially, and I don't want to dismiss anyone, but it does require a great degree of understanding of the scan in front of you and the patient state in front of you to say that this is as bad as death. Only the problem is when it comes to manslaughter versus non-manslaughter, that is not considered. So what some of the patients that come to me to clinic and their families say to us is they really complain about the fact that because effectively they haven't died or their relative hasn't died, the sentence was significantly reduced. I hear that actually a fair bit from the patients that come to clinic. So if we can bring that point to the Minister of Justice from a health point of view, that maybe ask us, what does a scan look like? Could they have died? Is that just as good as death? That should be probably in that realm.
So from your perspective, that black and white, did the person who was assaulted die or not die?
The final outcome, from my perspective, I can tell you is zero relevance.
Yes.
Because the final outcome depends on how good is our intensive care treatment, how good is our surgeons, how good is our ambulance service. That's what determines the final outcome. Just because you weren't found in a bush 10 hours later.
Yes.
But that does not mean that the assault was any less.
Yes, okay, that's a good point. Thank you very much. Okay. So there's a lot of support for that concept, obviously. Okay. Ladies and gentlemen, I don't have any further questions in front of me from our regional friends. Is there anyone else in the room? Who over there, thank you. Would you like to come forward to the microphone?
Hello, my name's John. I'm a security officer with Melbourne Health. I've heard some really positive stuff about new strategies, about the use of language, about not stigmatising unfair or stigmatising at all any individual. Training. What training strategies are in place to take that to the coalface?
So that's the question: is what are the training strategies in place to across the health workforce so that people understand the best approaches to dealing with this issue? Janelle, would that be something? And who's the best person? Who would? Janelle can start.
So we know that there's a varied degree of training and different health services have different providers, different training. So the main aim for the department has been around developing with the reference group the guiding principles to try and get some consistency across the state. And the next stage is then also to develop more tools and resources that can be embedded so that health services that may have had less access to training or have found it difficult can have access to more tools that they can fit within, and they can still continue with, I guess, the different arrangements and providers that they have, and also an evaluation framework so we can be determining whether they are actually, the training is meeting the needs. And I guess then on the security front, we're doing some work. As I mentioned before, we've engaged a security expert to look at guidance around security, and then the next step would also be then looking at that would include the training as well. But security is incorporated as well in the training, the guiding principles that have just not long ago been released.
Thanks, Janelle. And the training which Nicole's group is offered, and there are other providers, there is funding for training across the system, Nicole?
Yeah, the training that we have been contracted to provide along with a number of other health providers is specifically around managing methamphetamine use, which does include talking to someone who's intoxicated, aggression and managing violence, but also some other clinical management strategies as well.
Thank you.
And it's completely funded by the Victorian Government, so it's free to attend.
Fantastic. Did you want to make a comment about training briefly?
Just a quick one. When we got involved with St Vincent's back in about 18 years ago, we were asked to develop a non-violent restraint and control program.
Very briefly, if you don't mind, because we're about to wrap up.
Specifics were non-police, non-military, non-security techniques, so it was a new technology. And there's a lot of that technology that's out there, and there's very therapeutic response to aggression management. Yeah.
Thanks very much. And another comment down here?
Just as well, there's the National Centre for Education, Training and Addiction have got the online training package, especially for people in rural areas.
Fabulous. Are you happy for people to talk to you about that over lunch, perhaps? Or, yep, great. Sorry?
Can I just also, yes, that is available online, and the face-to-face training is linked to that. But also, I should say that the face-to-face training is all over Victoria, so we are going out to regional areas as well.
Brilliant. And Indigo?
I better stick safe words in there as well.
Yes.
So just mentioning at the moment, our focus, as we said, is mental health services. So we're going out and running Train the Trainer at 18 different services around the state and giving services the resources to then roll out that training internally. It's up to each service how far they take that training. So I can say, watch out within your service, but I wanted to remind people all of our training resources are freely available on the department website. So please feel free to access them, and keep an eye out as well in another 18 months or so when we start to look at rolling out training implementation in EDs and general health. So that's when even more opportunities come.
So I think you might have just answered the last question that came in, which is from Eastern Health, I think, over the web, the podcast, which says it would be great to see Safe Wards program implemented in acute, not just mental health. Is there any state level planning occurring on this?
Funnily enough, yes.
Good.
Yes. So the plan is mental health is the focus this year and next year, and then general health and emergency departments from then on.
Fantastic. That's great. Thank you very
Stay
much
tuned.
for clarifying that, Indigo. Now, ladies and gentlemen, we're out of time, and I know we're having quite a late lunch, and so everyone's been obviously very engrossed in what's been happening, but it is time to have a break. Can you thank all of the presenters from this morning? I think you'll agree it's been an absolutely fascinating and useful morning. Lunch is out in the foyer. We're coming back at 2:10 p.m. And if anybody is leaving at this point, just to let you know that there will be an evaluation conducted and you'll be contacted with a web-based tool to do that. But we'll look forward to seeing most of you after lunch.